Let's begin with part 2 of miscellaneous topics in obstetrics. So in the part 2, if you see, the recurrence rate after one neural tube defect in next pregnancy is 4%, and after two neural tube defects you have a chance of 10%. So diagnosis, what diagnosis we follow is screening test. In screening test we'll do this mother screening of alpha fetoprotein, and we do ultrasonography, or you can do both. And coming to diagnosis, in diagnosis you can do USG, which can be earliest, that is at 10 weeks, and the best scan is at 14 weeks. So in diagnosis, earlier we used to do amniocentesis, and in amniocentesis the best marker which you see is acetylcholinesterase, but now we are mostly using the ultrasonography. So what signs we see in anencephaly on ultrasonography? The first sign which you see is the frog eye sign, and the second sign you see is Mickey Mouse sign. So if you find the signs on ultrasonography, then you can confirm it a case of anencephaly. Now coming to spina bifida ultrasound signs. So in spina bifida, you will see the small biparietal diameter, and also you will see ventriculomegaly and frontal bone scalloping. The frontal bone scalloping on USG looks like a lemon, and elongation and downward displacement of cerebellum, and this is called banana sign because it looks like a banana. Now coming to prevention of neural tube defects. So neural tube defects can be prevented by folic acid. So prevention of neural tube defects is gestational diabetic. In a gestational diabetic female, also you will give prophylactically the 400 micrograms per day of folic acid, and to prevent the recurrence of neural tube defects you can give 4 milligrams per day in a pregnant female on anti-epileptic drugs. And also a parvovirus B19 of neural tube defects, in the previous history of neural tube defects baby also will give this same 4 milligrams per day. So this is called as therapeutic dose of folic acid, and that is called as prophylactic. So if you give 400 micrograms, that is prophylactic. If it is 4 milligram, that is therapeutic dose of folic acid. So this therapeutic dose should begin 3 months before pregnancy or whenever the female pregnancy, and it should be continued till 3 months after conception. But this prophylactic dose should be given 1 month before pregnancy, and it should end till 3 months after pregnancy. Now coming to from 4th month, of course we know we will give that anemia Mukt Bharat, that is iron folic acid tablets. We should continue them. So folic acid in the case of pregnant female with sickle cell anemia, the best dosage is 5 milligrams per day, or also you can give 4 milligrams per day. So what is the management of anencephaly? Finally you do termination of pregnancy. Now coming to intrauterine death of fetus. So if the fetus is dying inside the mother itself, that is a death of fetus beyond the 20 weeks of gestation, and now it is called as fetal death. It is divided into 3 types, that is early fetal death, later intermediate fetal death, later fetal death. Early fetal death is if the fetus is dying less than 20 weeks, then it is called misdeposition or early fetal death. Intermediate fetal death is between 20 to 28 weeks. Later fetal death is greater than 28 weeks. Now coming to, if a patient is having absent fetal movements, then we will do NST, non-stress test. And in non-stress test, if you get a straight line, then you can say it is absent fetal movements, and that is zero cardiac activity. So the conformity test you do is, again you will do ultrasonography, and still you find there is no fetus inside, then you can confirm it as intrauterine death of fetus, or you can say fetal death. So on ultrasound, what you will see if there is fetal death, the first sign you see is a Robert sign. So Robert sign is where there is gas in great vessels of fetus. Like in heart, you can say there is gas. The gas in small vessels is seen less than 6 hours. So less than 6 hours you can see gas in small vessels, but in great vessels you will see after 12 hours of fetal distress. Now coming to splading sign. So splading sign is an overlapping sign of skull bones. Skull bones will overlap. It can be seen greater than 7 days of fetal demise or distress. Next coming to ball sign. Ball sign is hyperflexion or hyperextension of spine, and it is overcrowding of spine which is seen greater than 7 days of fetal death. So wait for spontaneous expulsion of dead fetus. Actually this fetus, even though it is dead, it will spontaneously try to come out. Okay. So what is the management in the case of death fetus? that is wait and watch for spontaneous expulsion. But if the mother patient wants expulsion, she can't bear this death fetus inside, then we will go for induction of labor. And even after Intra-Train death is greater than 4 weeks, but still the fetus is not coming out, then there is a chances of DIC, so you need to do induction of labor. So coming to mode of delivery, you can do vaginal delivery for this death fetus, and if the baby is in transverse line, that too if she is in spontaneous, then expulsion is not yet started, then you can try external cephalic version and induction of labor. But already the patient is on spontaneous expulsion, then you need to do C-section. Now coming to important topic, that is Iugr, intrauterine growth restriction. So the weight of the fetus is less than 10% or less than 2 standard deviation. Then blood flow to the fetus is decreased. Then UPI, uteroplacental insufficiency is 80%. Then it is brain sparing effect, because even the low blood is coming to the fetus knows that brain needs more blood, so it sends all its blood to the brain. So head of the fetus will be normal, but the rest of the body appears to be small, and in that case that situation is called asymmetrical Iugr. 20% genetic, sometimes there may be genetic disease. In that case, the number of cells in the fetus will decrease. Symmetrical body size will decrease. That is, a whole body will be in the same size but will be somewhat small. But here the head will be very big but the body will be small. Now let us differentiate between the asymmetrical Iugr and symmetrical Iugr. So coming to asymmetrical Iugr, it is it is having a better prognosis, because it is seen especially in third trimester, and here the number of cells are normal. As the number of cells are normal here, it is better prognosis. Okay. It is it is the cause for UPI, that is the size of cell is decreasing. Decreased nutrition will first affect the abdomen, and on USG you will see abdominal circumference will decrease, weight of the fetus will decrease, and the last organ which is affected is brain or head, and the ratio of BPP by AC will drop, so that will lead to increase in ratio, and the ponderal index will be decreased. It is seen especially in third trimester, and the uteroplacental insufficiency will lead to decreased urine output by fetus, so it is associated with oligohydramnios. So coming to symmetrical Iugr, it is having bad prognosis because it is seen in first trimester, and here the number of cells decrease, and the size of cell is normal but the number decreases, and on USG you will see abdominal circumference decrease, weight decrease, BP decrease, heart HC decrease, and the ratio is normal here, and the genetic diseases are associated with chromosomal anomaly, and the ponderal index is normal. So coming to asymmetrical Iugr monitoring, due to PIH it will lead to UPI, that will lead to umbilical artery Doppler. You will do MCA, you will see redistribution of blood flow, impedance will decrease, so end-diastolic flow, reverse end-diastolic flow in umbilical artery. So change in Doppler of venous flow, ductus venosus, NST is non-reactive, fetal viability decrease, BPS decrease. Impedance increase, diastolic flow decrease, S/D ratio increase. So in this Doppler of umbilical artery and MCA should be done weekly, NST and BPP should be done bi-weekly, and in umbilical artery if there is AEDF, REDF, we need to do daily NST, and if in the case of this AEDF and REDF, we can do cesarean section. So coming to time of delivery, note that in oligo alone the termination of pregnancy is 36 weeks, that is between 36 to 37 weeks plus 6 days. In the case of Intrauterine growth restriction, umbilical artery alone, Doppler S/D ratio increase. If Doppler is normal, then the termination of pregnancy is 37 weeks, with AEDF 34 weeks, with REDF 32 weeks, changes in ductus venosus Doppler 30 weeks. In all, patients with Iugr give steroids. Now coming to amniotic fluid embolism or anaphylactic syndrome of pregnancy. So it is very rare. It causes PPH but rare. The most common occurs during labor. Its diagnostic criteria: abrupt onset of cardiorespiratory arrest or hypotension with respiratory compromise in first phase, documented DIC second phase, and clinical onset during labor, 30 minutes of placental delivery, no fever greater than 38 degrees, patient goes into unexplained shock after delivery. That is a amniotic fluid embolism. So by this we completed part 2. Next we start with other lesson.